Okay, so I'm sorry for those of you who are on Zoom who didn't hear the first part of the session, but we're kind of well into it. We went through a little bit about how competency-based medical education sort of started with the CanMEDS roles, and now we're trying to describe what entrustable professional activities are and sort of link them to how they're used in the context of competency-based medical education, because these are importantly and inextricably linked, and that's kind of the take-home point of my talk today. So if you learn one thing, that's the one. Okay, so we were describing what EPAs are, and now we're going to talk about big picture. Entrustable professional activities are professional activities that together constitute the mass of critical elements that operationally define a profession. So that's like a really big statement. So just have that sort of impact wow factor of like what this is saying. So from a big picture point of view, all the EPAs taken together actually make up the basic description of the profession. And again, think about the impact of this assertion and consider that most professional EPAs are in the range of 10 to 12 compared to competencies, which I showed in a previous slide, which are, in the 100 plus, right? So that means that there are many competencies that are actually packed into each EPA, and that's exactly the point. So this is a little bit of the nuts and bolts. So entrustable professional activities, they describe, again, I'm reiterating, but this is for purposeful repetition because this is the important element here, is that it describes work, clinical work that's actually done in clinical practice. So when we're talking about EPAs, it's very much centered around the task, the piece of clinical work, as opposed to the individual attribute of the learner or the PA. So when we talk about competencies, that's whether or not the learner or the PA is competent. When we talk about EPA, it's the actual task that we're referring to. And the EPA requires, obviously, a PA with the competency to do this work. And most EPAs, as we said, are made up of multiple competencies. And here are some important conditions of an EPA, which we'll break apart in the next slide. So an EPA is something that can be performed within a specific time frame, meaning that this is really important. It has a beginning and an end. It's a task that you can say, this is where it starts and this is where it ends. It's observable and measurable. This is all according to 10K and his colleagues. And it's a task that can be allocated to an individual PA. And it's suitable for a supervisor to make a decision about whether or not this is something that they trust their learner or their PA to do. So the E and the P and the A. For the task to be entrustable and professional and activity, it has to meet those three conditions, right? So the E, the entrustable, it means that this item is suitable for entrustment decisions, right? By somebody who has the authority to make that decision. The P is that it's actually restricted to a professional to something that's linked to being qualified. It's something that you need to learn to be qualified to do. And the A is that, and again, I stress that it's supposed to have a beginning, and it's a middle and an end. It's a standalone activity that's specific, observable, and produces a recognizable outcome that you can look back and say, this was done. This last one is especially tricky. Even when looking at the Royal College and the AFMC, the AFMC is the Association for Medical Colleges, the Association for Faculties of Medicine in Canada, so the medical schools in Canada, their EPAs, if you, some that you can pick out that don't actually seem to meet these criteria, which is very interesting. So there is some controversy and debate that's sort of percolating around this question about the task versus larger areas of domains. Okay, so let's get back. I'm sorry. Here's the E and the P and the A. I forgot to advance that slide, but basically everything we just said. Okay, so we get back to Sarah here, right? So what does this mean for Sarah and for her learning? So almost any task that you can think of in clinical practice requires more than one, and usually a combination of several competencies. Okay, so you can see that there's 3 EPAs here, whatever they may be. Each one of those, that you've got the 7 roles of the CanMEDS competency on the left side column. And you can see that different EPAs are made up of combinations of different roles, and within those roles, different competencies. So we've kind of just broken down high level here. And some require more of one than the other. So I've sort of indicated that by 2 pluses or 1 plus, you know, that's not exactly scientific, but the idea is that maybe one is more medical expert and less, and one is more collaborator and one is less. Some of them contain, you know, some of them, as you can see, are missing some of the roles. So not every entrustable professional activity necessarily involves being a manager. Whoops, that should be leader. Sorry about that. Or health advocate, right? Manager is the old role. That was changed in 2009. Okay, so, right, so where am I here? So yeah, so almost any task you can think of has a lot of these competencies. So by focusing on the EPA, which is, again, the unit of clinical work, you automatically include all the competencies that make up that EPA. And if the learner can perform the EPA with the appropriate level of supervision for her stage of learning, you can infer that she has achieved the required competency. And this is so practically helpful, both for teachers and for teaching and assessing, and as we know, for program accreditation now. If you can teach and assess these work-based activities, you don't have to worry about checking the boxes for each individual competency. That's kind of the point, right? And a well-organized curriculum map using EPAs will include all the competencies sort of by default, because they're all packaged in the EPAs. So it turns out to be a more holistic approach. So going to the idea of levels of supervision, different levels of supervision reflect the increasing trust in the PA being able to perform a specific EPA autonomously. So the highest level, you go from where the supervisor has to be present. No, sorry, the learner is present, but is not actually permitted to perform the EPA. So basically this is they're observing, right? And then you go, the learner can perform the EPA with direct supervision, meaning the supervisor is standing right next to them, ready to jump in, lend a hand if necessary, corrective response. And then the third level would be to perform an EPA with indirect supervision. So the PA can do the work, the supervisor is around, maybe in the next room, maybe not even necessarily in the building, indirect supervision, but they can be called in as needed. And this is what we consider in PA learning the entry to practice threshold, where we consider the PA learner competent to go into practice. And then beyond these, you have performing the EPA with only distant supervision. So I kind of made a leap there from indirect being nearby and to distant supervision being the example we gave in alert. And then finally, for physicians able to supervise, sorry, not for physicians, but I'm not including here not requiring supervision, right? Because I made that distinction with PAs. And then finally, there's another level, which is really teaching, right? To able to supervise a junior learner. So that's where the learner becomes the teacher. So what this looks like with Sarah. Okay, so it's maybe a little confusing. We flipped the EPAs now to the left-hand column. Can you guys see? Yeah, more or less. Okay. No, just from this side, because there's sort of where they're sitting at, I think it's blocking. You can see, that's awesome, it's right there. Right, so these are 3 different EPAs, again, whatever they may be. And with those different levels of supervision that I showed you in the previous slide, you can see that different EPAs have sort of a different learning curve, if you will. So ideally, each PA learner will reach this entry to practice competence for each EPA by the end of training. But the levels of entrustment may be reached at different times for different EPAs, as you can see in the image. And these milestones may even be reached at different times by different learners across the continuum of learning. So it can be quite individual, and that's sort of the point of competency-based education, that it's not time-bound like the T-steeping method, but more attainment of abilities to do things. And again, looking at here, you can see that EPA 1, the learner in year 1 can observe in year 2, or maybe even later in year 1, they can start doing it with direct supervision. And then at the end of in year 2 or at the end of the year, they can start doing it with indirect supervision. And similarly for EPA 2, they may be able to start doing it with direct supervision earlier and indirect supervision earlier. And then EPA 3 is, of course, a little bit reversed from that scenario. And when it comes to assessment, so typically, assessment in education provides some form of grades, right? We're used to ABC or 70, 80, 90%. But in the case of clinical work, we know it's not exactly like that. That doesn't tell us much about the ability to entrust clinical duties to a learner. The language of entrustment allows the supervising clinician and the learner to think of assessment in terms of patient safety, right? The focus is shifted. It's like, can this person be trusted to take care of this patient? Is this a safe situation for everybody involved? And also in terms of rights and duties to practice professionally. So it shifts, again, the lens away from grades and marks and things that don't really have a strong attachment to real clinical work. And it also tells us much more about the learner's ability than a number or a letter grade, which are kind of, kind of an indirect indication. And another benefit, which is very interesting, that's been found, is that it also encourages supervising clinicians to start thinking of their learners as future colleagues. Think about that one. Okay, so this is an image that was taken from Ten-Kate's earlier work. I think this is 2010, or no, this is this work done by him and his colleagues in the Netherlands in the early 2000s. Is that called aughts or something? I never remember that, like the first, 2005, the aughts, yeah, we'll call it that. And this is essentially a curriculum map of EPAs for PAs being trained to work in a neurology service in the Netherlands. Now, the training in the Netherlands is a little bit different than in North America. And so it allows this degree of focus. You can see that it's very, can you guys see some of the EPAs? They're very focused and specific and very skills-based, right? Most of them. Yeah. Mm-hmm. Mm-hmm.
That it can be set at whatever. Whoever's providing it would create it based on their CanMEDS and correct.
Exactly. So different organizations. It's more, I think, Ten-Kate and his colleagues recommend that it not be done on this was like almost like a pilot. This was a study to develop EPAs. And it's interesting because it was done in physician assistant education in the Netherlands, because I think he was also very much instrumental in starting the PA initiative there. But the idea is that not each school necessarily should do its own EPAs, because then it becomes a little unwieldy, and then we're not like learning from each other, and the cycle of renewal doesn't. So yeah, so they do want it to be like on the level of, and we'll get to it because one of our esteemed members here, program directors here, Kristen Burrows, is one of the authors of the Canadian EPAs for PAs that just came out in 2021. And so the idea is more that it's on that level of organization, professional organization. But that being said, schools do individualize the EPAs. So for example, for the medical schools, like I told you, the AFMC, the Association of Faculties of Medicine in Canada, they have come out with their own, I think 12 also, EPAs for medical learners. So what they should be able to do on day 1 of residency. But the medical schools have taken those and actually subdivided those so that let's say for medical school at U of T, they have certain ones of those that are for year 1 and year 2, and certain ones of those that are for, so they've gone further and subdivided them further. So it's case by case, I guess you could say, but in a general terms, I think the idea that it should be done at sort of a professional. So for example, yeah, for accreditation, all the schools in Canada follow the EPAs, for PAs, the CanMEDS ones, yeah. Okay. Speaking of the Association of Faculties of Medicine of Canada, this is, yeah, so this is timely. So this is their EPA list, and there's 12 on here. I wasn't sure what size font that would come out. I wouldn't be able to read that if I were you, but that's just to let you know that there are 12 of these. They're Canada-wide core clinical activities that all medical students should be able to perform with an indirect level of supervision, meaning the supervisor is not in the room, but available to provide assistance on day one of residency. And then, like I said, the U of T undergraduate medical curriculum is based on these EPAs, and they're further broken down into foundation, which is the first 2 years of medical school, and clerkship, which is year 3 and 4. So to your point. And oh, I wanted to point this one out. The first one says, obtain a history and perform a physical examination adapted to the patient's clinical situation. So just keep that one in mind. We talked about these, yeah, about which ones were, you thought, okay, so we'll get to that. Okay, so here we are, Canadian, finally, after all that. What time are we at? Okay, good. So these are, there's 12 of them. I've just broken them down into 6 on one slide and 6 on the other slide so that you can hopefully actually see these. So these are the Canadian EPAs, we call it EPA-PA, the framework, like I said, developed in the by the directors of the 3 civilian PA programs at the time, and went into effect in 2021. So those leads would be Leslie Nichol of the University of Toronto, or the Consortium of PA Education, Kristen Burrows, who's here with us today, McMaster in Hamilton, and at the time, Ian Jones in Manitoba. Thank you very much. Great debt of service. So these EPAs actually do overlap quite a bit with the AFMC EPAs, and that's a good thing because we don't want to reinvent the wheel. And also similar in some ways to EPAs developed by similar levels of training, which tells us that the authors did their homework and looked at what was available and kind of adapted it, again, similar to CanMEDS, adapting and adjusting to meet the needs of PA education. And in fact, some of these are not actually identical because, again, being a slightly different profession than medicine, you're going to expect there would be some variation, but definitely some overlap, right? And these are the second. Oh, 1 second. I wanted to go back to this. Okay, so again, there's that one that I mentioned from it. Faculties of Medicine. So obtain history and perform physical exam. Demonstrate the clinical judgment appropriate to the clinical situation. Wow, I did not highlight the exact same one. I meant to do that. Where did that one go? Oh yeah, it is similar. Okay, yeah, it's the same one. Okay, so you see that that's the overlap, right, that I was sort of talking about. And then these are the next 6. Yeah, I'll just give you a minute to peruse them if you haven't seen them yet. But we're not going to go into deep dive on most of these. Okay. I encourage you to look at these. They are on the CAPA website, of course. If you go about PAs, and then there'll be a drop-down menu, and the EPAs and CanMEDS are both documents are right there. So a little bit about the structure of an EPA. So EPAs should have roughly these 5 components. I highlighted the main 3. I'm not going to get into the first 3, but I'm not going to get into the last 2. So a title, of course, you have to say what the EPA is about. And then there's a description of the activity, which includes, any limitations. And then there's the link to the competencies. Aside from that, you want to know what the source of information is to determine progress. Like, how will you know when that learner is actually ready to be entrusted, and the basis for formal entrustment decisions? So who would be entrusted? So let's just look at the first 3. So here is an EPA, the one that we were talking about, obtaining the history and performing physical exam. So this is really nice and very basic to what PAs do, right? Demonstrating clinical judgment according to the clinical situation. Like, you can see that there's a lot wrapped in this. This is basically doing the history and physical, right? So can anybody see well enough to actually read the definition of this one, or can come up close? Yeah, great. Go ahead. Remind me your name. Thanks, Jessica.
Should apply their knowledge, skills, and patients in a manner solely pursuing predetermined protocols. PAs must perform an accurate, complete, or focused history and physical exam and prioritize or organize manner tailored to the clinical situation and specific patient encounter. PAs need to integrate the scientific foundations of medicine, social factors, and critical reasoning skills to guide information gathering.
Thank you. I want your eyes. I'm very jealous. Okay. Yeah. So very clear, right? It says just what it is. You can see that this involves a lot of different competencies that are sort of packaged into this description, and then into this definition. And then if anybody can, we're not going to go to the bottom part, but just that middle box. Can anybody read the description, the 3-part description? Is anybody else as sharp-eyed as? Yeah, go ahead. Young people.
Two, the PA needs to demonstrate appropriate judgment through an additional assessment beyond their skill level required. Point 3, the PA must adapt their educational or clinical skills to their environment, clinical situation, and their patient.
Okay, thank you. And what's your name? Quaker, thank you. Okay, so again, very detailed and clear description of what that is. So, and when you move down on the slide, I guess, like I said, we're not going to actually read it, but you can see that it lays out which of the CanMEDS competencies are actually encompassed in this particular one. So you can see here you have elements of the medical expert. That makes sense, right? The communicator, of course, this history and physical piece. And the advocacy, which is interesting, respond to individual patient health needs and issues as part of patient care, and identifying determinants of health, which is so critical, right? So that is the basic anatomy and physiology of an EPA. Just wanted to drill down. I'm not going to get into this building on CBME. This is sort of what the Royal College does. They have something called milestones, which is just a nice way of saying CanMEDS competencies at different levels of residency training. Okay, so we'll talk now a little bit about some challenges and misconceptions. So EPAs are not the same as competencies or skills, right? So competencies relate to the ability to do something, right? Similarly, skills relate to the ability to do something with precision and certainty. And both of these relate to the individual's ability to do these actions, right? So it's focused on the individual. Can this person do this thing, right? But EPAs are not individual attributes, but rather it's, again, repeating myself for the point of, emphasizing this point, that it's the unit of work to be done, and the individual demonstrates their ability to do this unit of work or task by using their competencies or skills. So that's the distinction there. Not all learning objectives can be framed as EPAs. This is really important to us as educators. So Tenkate uses the example of a person who speaks Arabic, for example. This is an ability that the person possesses, but this ability in itself would not qualify as an entrustable professional activity. However, acting as a professional interpreter, for example, like in an international policy meeting, would qualify as an entrustable professional activity. It meets all the standards for the E and the P and the A, right? And aside from the basic ability to speak the language, the person would also need other competencies to be able to act in that role. They would need the knowledge, let's say, about confidentiality rules in that setting. And they would also need attitudes such as integrity to fulfill that duty with, honesty and to the best of their with integrity, right? So by this example, there are a number of EPAs that have been identified in the literature, not me, the literature, that they have not actually met the criteria for EPAs the way we've spelled them out. And the examples cited in this article are from the US core EPAs for entering residency. So one of them, for example, is collaborate as a member of an interprofessional team. And another one is identify system failure and contribute to a culture of safety and improvement. So hopefully by now, the way we've described EPAs, you can see that those don't actually work within the frame. They're important, right? You do want to teach those and you do want those to be part of the educational system, but and for PAs to practice in that way, but they're not in themselves tasks or units of work. So they don't actually qualify as essentially EPAs. And this problem poses a big challenge to mapping EPAs to healthcare curricula. We saw this in recent accreditation reviews. EPAs are really most relevant and applicable to clinical tasks. So they apply best to clinical training. So for example, many of the foundational courses in the PA program in the first year are somewhat removed from EPAs. And those learning objectives in those courses are so specific and granular that it becomes a little more challenging to link them to EPAs. On the flip side then, there's this overarching learning objective in the curriculum that may be too expansive or broad to link directly to EPAs the way the examples I just gave before. So 10K gives some solutions to the problem of learning goals, of learning goals that do not work well with EPAs, but ultimately concludes that not everything that is important for clinicians can or must be an EPA, which is interesting to say after all of that. So we're getting close to the end. I did when I did this session before, I asked participants to kind of look at the EPAs. These are the American ones again, so I didn't want to pick on anything Canadian, right? But just to pick the ones that they think now that you know a lot about EPAs, which ones actually match the criteria of EPAs and which ones are problematic in that sense. I can tell you that one group of researchers did this, created this sort of rubric to look at EPAs and kind of test them out, right? Is it a discrete activity? Is it an entrustable and a professional activity? And sort of the EPA as an educational tool. And the results of their survey was that looking at those same EPAs, those Association of American Colleges EPAs, only one of them, in the view of these experts that used the rubric to look at the EPAs, actually met all the criteria. It's a very interesting paper if anybody's interested. And a bunch of them, the red one, so the green one was the one that they felt met the criteria. The red ones, there's 4 of them, they felt should not be EPAs, and the rest they were like okay with, but you know, they had suggestions for each one. So only one was like, yeah, you're good to go. So it's very interesting. Okay, so take home points. CanMEDS is a good framework for PA education, but it's not perfect. EPAs do provide a link between competencies and clinical practice, and that's important. Like I said, that's kind of the key. EPAs and CanMEDS complement each other, so it's not one or the other, it's both and. And EPAs may define the PA profession to some extent, but not everything that is important for PA practice can or must be an EPA. And so Sarah will complete her education and we will give her the keys to the car. There are my references. Thank you very much. So we're at 3:03, so we went over a bit. Sorry for all the technical delays, and especially sorry to people who are online. You can get in touch with me. I didn't put my email on here, but it's sharona.kanofsky@utoronto.ca. All the U of T emails are the same, first name dot last name @utoronto.ca. So if you have any questions, you want to get in touch with me about this, happy to answer any questions. We also have an expert in the room. So I don't know if anybody's rushing anywhere, but we'll formally close this session. And if anybody wants to talk about it or ask any questions, I have nowhere to go. Okay, thank you very much.
From the Geminis.